Orringer, good morning.
Morning, Joe.
Thank you very much for your interview with us at the American Association of Thoracic Surgery Conference here in Toronto. In this series of the Giants of Thoracic Surgery, we would like to discuss with you the procedure which you helped pioneer, the transhiatal esophagectomy for resection of the esophagus. Specifically, we'd like to review with you some of the key steps to making this a successful operation and discuss in a similar way the way you might walk through the procedure with some of your residents. I'd like to start with a question on perhaps a preoperative workup and wonder, in this era of more and more diagnostic testing, do you think a PET-CT and an endoscopic ultrasound are absolute requirements or optional for a preoperative workup?
In the evaluation of patients with esophageal carcinoma, the CAT scan followed by the PET scan followed by endoscopic ultrasonography have become state-of-the-art at the present time, and that is typically our standard. Now, if a patient has a CAT scan that shows stage 4 disease, the need for us to pursue any further workup before forwarding the patient to the oncologist obviously doesn't exist, but in the typical surgical patient, all three of those studies are routine now.
How about specific measures prior to surgery? You're interviewing a patient today, and you find out he's teed up for surgery, but he's actively smoking. Would it stop you from the operation? And if it does stop you, how long do you think you're safe to delay, given, of course, the concern over the cancer progression?
Well, Dr. Lukatich, that could be the subject of the entire interview this morning, because I believe in my mind that with all the surgical advances that you've developed, that I've developed, probably the key factor responsible for our decrease in operative mortality and morbidity has to do with how we prepare our patients for the operation. We have an absolute mandate that we follow that patients must abstain from cigarette smoking for a minimum of 3 weeks before surgery. Now, because the majority of our patients with stage 2 and 3 esophageal cancer have neoadjuvant chemotherapy and radiation therapy, there's a time lag before the operation anyway, and this presents no hardship. But I'm fairly unyielding with that. I think that majority of our patients who come to us with esophageal cancer have had their tumors for 12 to 18 months before they ever see us, and so to add a few weeks at the other end so that they have a more successful surgical outcome is well worth the investment. And the smoking is one issue. The other issue has to do with ambulation. We have our patients walking 2 to 3 miles every day. I'm easily able to tell them to do that because it's what I do, and I tell them I expect you to do what I do. And we get them walking so to condition themselves for early ambulation after surgery, because they're told that they're not going to the intensive care post-operatively, and they'll be expected to be up and walking the next day. And if the expectation is set, inevitably patients do it. So the walking, the abstinence from smoking, and then we issue patients an incentive inspirometer, which typically is handed out after operations all throughout the country and the world after surgery, where the poor patient with an incision is given their little plastic toy and told to inhale and to deep breathe, and they look back at you and just wonder, what on earth are they asking me to do with all this incisional pain that I have? But patients who have been conditioned to do this and to take 10 deep breaths 3 times a day before they come into the hospital already have a respiratory program underway, and they get annoyed at themselves when the first few breaths after surgery aren't as good as what they were doing beforehand.
Now, you're in the operating room. Your patient's ready. He stopped smoking. He's asleep. Do all patients get an endoscopy by you on the table, firstly? And prior to your midline laparotomy, do you think it's advisable for that small percent that are missed by PET, CT, and CT to start with a laparoscopy prior to, even though you may be intending to open if it's a go? So the two questions: EGD, your own endoscopy on the table, and would you consider laparoscopic staging prior to a midline laparotomy?
I think it's been a principle of good thoracic surgery, going back to Dr. Alexander, that if you're going to operate on a thoracic organ, you look at the inside first. And we would never do a pulmonary resection without looking down the airway at the time of surgery to be sure there are no surprises. And similarly, we would not take out the esophagus without looking down first. There are enough patients with skip lesions, with abnormal esophagus proximal to the